All right, I think we'll try to get started here. Thanks everybody for coming. It's really good to see everybody. I'm Lisa Miller. I'm the director of the Preventive Medicine Residency Program, and this is one of the Preventive Medicine Grand Rounds / Epi seminars that we do together. And I'm really excited to introduce two people. We're going to have two speakers today, so 2 for 1. And this is an example of public health practice and academia working together. So it's something we want to really highlight. The first speaker is going to be Dr. Seth Foldy. And Dr. Foldy is relatively new to Colorado. He just came, I think, in late 2017, December 2017. He is at Denver Public Health, where he's the director of epidemiology, preparedness, and informatics. But before that, he had a career as a public health practitioner. He's worked at the local public health level, he's worked at the state public health level, and he's worked at CDC. So he was the Commissioner of Health in Milwaukee, State Public Health Officer for Wisconsin, and then worked in the informatics office at CDC. So it's great to have all that public health practice experience here in Colorado. And then Tessa Crume, I probably don't need to introduce. Everybody knows Tessa. Tessa is an associate professor here in the Department of Epidemiology, and her focus is perinatal health. And she will explain her connection to CHORDS shortly. So take it away.
Thank you. Thank you very much. Please let me know if you can't hear for any reason or have any problems with the technology. I'd like to acknowledge our millions of viral followers of the recorded webcast of this event, and thank everybody for coming today. I have a nice update for you. This is a, hey guys, it's ready for use presentation. I'm actually awkwardly aware that many of you in the audience may have built CHORDS. I had very little to do with it. I'm just transmitting the good news about where it's gotten to at this point and a few places it's going to in the near future. Our objectives today are to make sure, do a little level setting in the room, make sure people understand that, guess what? Medical records are now electronic. It comes with complications. It comes with great benefits. Distributed query is one approach to doing research or surveillance with those electronic health records. CHORDS, there are many distributed query research programs out there. Compass is one you may have heard of, PCORNet another, but CHORDS is a different animal, and there aren't very many of them around. So in some ways, you're very fortunate to have this in the greater Metro Denver area. Some improvements that have recently been made or are upcoming that you might not have been aware of. How you today can tap into CHORDS and start pulling down data sets for your educational or research or public health surveillance projects. And then from Tessa to learn a lot more about what it's like to be in the field. This is only for the residency people. When you're looking for the competencies I'm covering, here you got them. Everybody else can ignore that. So on the left was when I was back when I was a kid and we had to do research. We would climb these stacks of paper medical records, which in some ways were really easy. You would go to the record room, they would have them ready for you. You'd go through them, you'd extract information. But what you see in the graph is the adoption curve for electronic health records: 34% for ambulatory physicians in 2007. Going up to 86% in 2015. This, as you probably know, was driven by fairly major federal funding incentives. One nice thing about those funding incentives were that they also required the EHRs to have some degree of data standardization and data exchange standardization that makes it somewhat practical to move data in and out of EHRs for other functions like public health surveillance. Electronic health records are easy to get to if you are electronically signed on to them, but lots of obstacles if not, partly due to privacy and security. So they can be very fast, they can be very inexpensive to search once you have access to their databases, but you have to overcome some obstacles to get there, and the CHORDS system is one approach to that. CHORDS is a network conceived now with, 8 years ago, that uses EHR data to support both public health evaluation and public health monitoring and public health research and other clinical research. And to address quickly those privacy and security concerns around electronic health records, most of you have probably encountered HIPAA, the Health Insurance Portability and Affordability Act, which created some safe zones for exchanging electronic standardized information, but also created a higher visibility to the risks of doing so. HIPAA requires patient consent for most research projects if the records that you are going to obtain about that patient contain a certain level of personally identifiable information. It requires also consent for doesn't require patient consent for authorized public health uses. So me, if the law tells me to do disease surveillance, I can look at records. You, if you have a public health master's project and you want to address some questions about the prevalence of illness in a community, may not be covered as an authorized public health use. Obviously, it is possible to steal large quantities of electronic information relatively easily, as you are no doubt aware. And so a result of these is if you want to do studies, but you want to reach people who are not consenting to having their data used, you have a real problem using electronic records. If you are trying to do information exchange across multiple institutions for research or even for public health use, it can be very awkward to do so. And that's where the architecture of CHORDS comes in. It is a query service, and basically in the purple boxes, you'll see each of these are basically individual healthcare provider organizations. They may be very large, like Kaiser, Colorado. It may be fairly small, like a mental health community health center. But each of them with their own data behind their own firewall in a virtual data warehouse. And then that is queried by a centralized query service. So the warehouse is standardized, but it's safely in their own domain. You'll hear the term distributed query in this talk. The term a federated system or federated query refers to basically the same thing. The data stays where it was born and is only exchanged in aggregate or otherwise highly secure ways when needed. And so some of the how and whys, there is a software called PopMedNet that fuels many distributed query systems, including PicorNet, including the health insurers. I will see the name of it in a few minutes. A variety of other systems, and is also utilized by CHORDS. Again, the patient remains secure in the provider's side of the firewall. Data partners retain control over whether or not and when they share it for a particular project. In general, aggregated data is shared rather than individual data that could be used to identify patients. And therefore, traceback to individual patients is either impossible or very highly regulated under very strict protocols. And so if you were to go out, if you're going to try and ask a question, how many people were seen by many different healthcare providers in metropolitan Denver with condition X, you would have to go off and negotiate, create the technical, the legal, the permissions, the research permissions, individually with all of those institutions. By creating a shared infrastructure to do this one time for many investigators, for many projects, we've greatly reduced the obstacles to doing research using electronic health records, thus making each query much lower cost than going out and doing it yourself with electronic health records. And of course, being able to query electronic health records over the course of just a few days is a whole different animal compared to trying to get thousands of patients to answer a survey, for example, for similar information. It consciously has included providers serving underrepresented populations and when I say underrepresented, I mean people who don't always get to tertiary medical care centers because, yes, Vanderbilt has a system for this, and Harvard has a system for this, and even UC has a system for this. But if you wanted to find out what patients were experiencing at community health centers like Clinica, you have to work to get those people into your system, and CHORDS has been very self-conscious about doing that. It integrates not just primary care data or inpatient data, but emergency department, mental health, and other data sets. And it's continuously growing, and it can be reused anytime you like as the database grows. Another way CHORDS is a little bit different is on the left, you'll see that distributed query with a lot of health record systems, but that are in very different locations. So PCORNet does research on mostly tertiary care, academic medical center, electronic health records, but they're all in different communities. Again, might be Vanderbilt, Harvard, and Cincinnati. What CHORDS has done is get a lot of institutions in the same community to contribute their files about that same community. So it allows us, you can imagine you couldn't do any kind of surveillance on the left, except surveillance of patients who happen to be going to tertiary care, academic medical centers for this kind of care. So you can use it for lots of research questions. But if you want to actually answer questions about a population over time, you need this overlapping model like CHORDS has begun to build. Needless to say, it's not easy. It took 7 years to get where we are today for a reason. It took a lot of partners. Those partners include the data providing partners, and you'll see who those are in a moment. The very important role of the convener, the people who actually set up the various committees to make everybody feel like this is okay and to make judgments when certain special requests, for example, are made, the governance of data and data access, technology partners, both here at the university and at our electronic health information exchange, CORIO, which has capabilities that nobody else really has in this space. And then the data users, which include researchers, but also public health departments, the 7 Metro Denver departments, Weld and Larimer departments more recently, as well as the Colorado department.
How about Kaiser Permanente?
Kaiser is one of the data contributors. I thought that was going to come up next. Let's see if it, where did that slide go? Uh-oh. Ah, there we go. So thanks. These are the contributors of data currently. They include Children's, Denver Health, Kaiser Permanente. You will notice some significant gaps on this list, and we are very hopeful that 2 things are going to happen as a result of this talk. One is you're going to go out and use the system today, and the second is, of course, you're going to kind of keep pinging your institutions about, hey, when are you going to contribute to this system? But there are several other large systems that are in active negotiation to participating. But also mental health providers, which is somewhat unique for us, as well as a large variety of community health center contributors as well. Okay. So one of the things about using electronic health records is they contain an awful lot of words. I mean, it's estimated there are more than 150,000 independent concepts used in medicine on an ongoing basis. Each of them have about 50 to 60 different subtypes of values, and then it just gets horrible. So if we took all of this and put it into a virtual data warehouse, it would never work. So you need to understand that there is a data model that helps organize information into appropriate categories, as well as maps many of the relationships between those categories that then become more highly computable for your use, which you will thank everybody for when you get there. Now, your average EHR system like Epic may have as many as 12,000 tables in their data model. CHORDS decided it might be impractical for the research and public health community to go there. Currently has simplified a lot of this data of the highest interest into about 18 tables to work with. And they include such items as who is paying for this care, what diagnoses were given, what type of encounter was it? Was it an emergency room visit or a primary care visit? When did it occur? A variety of very discrete laboratory results, but mostly ones of high preventive interest like lipids, glucose, alcohol, hepatitis, TB. Patient demographics, of course, but typically anonymized. It is linked to census information, small area census information for each patient. The prescriptions that were written and the quantities, procedures that were undertaken during those medical encounters, social history that was collected in the social history part of the chart, vital signs, including, for example, height and weight. Sorry, I have an itch. And linkage. Now we're finally getting to the point where we have an ability to link individuals by a common but untraceable ID that will allow us to deduplicate records from different providers. Yes?
In regards to the linkage, outside of what's been done in Denver, what about other things such as Medicare, Medicaid, linkage?
Linkage, say, to insurance records. We do not do that here currently. It is, and remember, so you will get into this in a second, but many of the public health surveillance uses, you're not getting individual records, so we can't have you do that linkage after the fact. Researchers can start developing special data use agreements, get individual level data, and potentially make linkage, and you'll hear about that from Tessa. And then there's some other very interesting projects out there that are very early stages, like the census is actually looking at being able to take individual census records, a lot of other federal data, and healthcare data, put it in one incredibly safe Fort Knox with a very, with a somewhat difficult to use, but probably worth it system for accessing that data. So those other kinds of linkages are gradually becoming available in some ways. Yes?
Does it also contain information about what healthcare professionals outside of prescribers that they come into contact with?
I'm thinking yes, as part of the encounter data set, but I'm not 100% sure. It does, okay. I'm told that it does. And then we won't spend much time on this slide, but you see that railroad track down the middle. That is a zone where people can control greatly how much data passes. So you, the user on the left, asks one of our project managers or maybe a health department to help them. They'll submit a query to the various hospitals on the right. Each hospital has its own data mart. They analyze the query and might give it back as aggregate information about that query. We have 347 patients that meet the criteria you're describing in terms of date, place, time, diagnosis, etc. Here's the summary of the information you asked for. The distribution of hemoglobin A1Cs looks like this, and the medications they receive for diabetes look like this, and you get it back after the data mart administrator at each institution decides that this is both meaningful information and not misleading, and also doesn't violate any privacy concerns that they might add on top of CHORDS minimum data requirements. It is then submitted, aggregated as one aggregate, and you get one data table that shows everything you asked for. Now, obviously, the best system possible would contain all possible people in it. We're not there yet, but you will see that, now this is before deduplication has been done between different providers. But we have very high level of penetrance in Denver County, in Adams County, in Arapahoe, and in Jefferson. As you go a little further away from the core of the city, it starts to taper off. We'll need to be adding more providers that are more active in the suburban zones to increase that degree of penetrance. So you might ask yourself, when might I want to use CHORDS? When or shouldn't, why do this? Don't we already have the behavioral risk factor surveillance survey and the PRAMs for pregnancy and the this for that and the that for this surveys? And the answer is yes, but. Because those surveys have advantages that CHORDS may not. You can make them ask anything you want, including things like, tell us about your behavior or tell us about your attitudes. You're usually not going to get attitudes out of an electronic health record, not as structured data. You might get an attitude, but They're relatively easy to make sure you're not dealing with unduplicated records. Some of these surveys go back years and years and years, so you're going to want to use those if you want to look at trends for what BRFSS has said about smoking for the last 150 years. The items are designed for the data user, but one of the things to be aware of in CHORDS is we're taking information out of electronic health record. That data was recorded for doctors and nurses and administrators to use, and not necessarily researchers, so it may not be designed for use the same way. And of course, CHORDS accesses information about people who are receiving care and not people who are not receiving care. So these are advantages when you might need survey approaches, but CHORDS might be able to give you a much lower cost per query. You can, if you make a mistake, you go back and re-query right away. It's trivial. Try that with a survey. You can get doctor level, validated opinions about diagnosis, the phenotype, what the patient's blood pressure is. It's not recall, by the patient. Deduplication is coming, which is one of the exciting points of today's lecture. I'm not sure why this is. There we go. You can't fatigue our computers the way you can with a long survey. You can go back and look at longitudinal records over time, which surveys, of course, tend to be cross-sectional. So these are, and finally, these are massive numbers you're getting out of CHORDS. So you can create extremely narrow confidence intervals for fairly small populations, like back or small subpopulations. So there are some advantages to CHORDS as well. First time CHORDS was kind of envisioned, people asked themselves, could we use electronic health records to see where children with high BMIs live in city census tracts? And they discovered that just with Kaiser and Denver Health data alone, they were able to represent very small neighborhoods. Now, of course, there is some skew if you use only those two organizations. But this was, if you will, the first test case. Today, they have now built several adapters, which are basically pre-built queries that you can then request in any number of ways. So you could take that childhood BMI query and say, well, I'm only interested in Arapahoe County between 2009 and the present, and give it to me in annual breakdowns by gender. And this is all pre-built now, along with a cardiovascular adapter, diabetes, liver health, some newer mental health adapters, substance use, and tobacco use. And these are actually available to you just about as simply as calling your local health department, finding their CHORDS contact, and saying, would you mind helping me access this adapter? Or you could call the project managers you'll see at the end of the slides. Will the slide deck itself be available for perusing as well as the tape? Yeah, because you'll want to, otherwise you'll have to scribble down some, otherwise you take my card. So we were asking some about, so I was trying to find good case of example where I could take CHORDS and compare it to something like BRFSS. And I don't have it yet. We're actually we're in the early stages of working on a paper about tobacco use to compare those. But some things to be aware of when you try and compare CHORDS, say, with survey data. So this shows, I asked staff, I said, give me the latest from CHORDS, give me something you have to hands on CHORDS for the prevalence of depression, and give me BRFSS. And they gave me these. But the more I looked into it, BRFSS item is, have you ever been given a medical diagnosis of any of the following disorders? Whereas CHORDS is searching for this year. Are you seeing that diagnosis? So just as an example, one of these days I get this button straight. But obviously BRFSS, has its one-time question with recall entering the equation, self-report biases. On the other hand, CHORDS is biased by the fact of being a recorded medical diagnosis. You had to get that far to show up in CHORDS. And CHORDS does include the possibility that somebody might have been seen for depression at 2 providers, thus giving you a count of 2 instead of 1, leading us to the excitement about deduplication. On the other hand, CHORDS can give us very nice small level data, so long as we recognize that it is prone to some of the biases that we have to take into consideration. So researchers can go to CHORDS and design far more granular, well, public health can too, but we have the option to design far more specific and granular uses of the CHORDS data model. And some of the examples that have already been done was to look at data on asthma exacerbations, long-acting contraception and adolescent pregnancy, spinal fusion procedures, and opioids. And in this situation, CHORDS solves a lot of your problem by facilitating the process of making a rather complex data query to many providers at the same time, rather than you having to go from door to door as though you were the first person on their doorstep. So the healthcare provider is getting your request through CHORDS. They know it's been subjected to a certain level of group approval, and hopefully you can get this. And our experience is that researchers are able to get this information a little more easily. So, for example, you have information on prescriptions here on the right, prescriptions over time. On the left, it just shows you the level of granularity you can get down to with a specific laboratory type, like the absolute number of eosinophils in your blood as compared to the percent of your eosinophil count. So you can look at trends even down to that level. Weighting of CHORDS data. Obviously, since not everybody ends up in the hospital, you want to be able to make your CHORDS data a little bit more representative of people who may not have been there. And this can only be done each time you run a query, because every CHORDS data request really does create a new data set that you need to weigh. And CHORDS can't just do it for every evaluator, every researcher or public health user on the fly. What is good news, however, is CHORDS and its partners have undertaken to create both SAS and R programs to do this. So if you have access to either of those programs, we can hand it over to you that would allow you to do the necessary weighting for age, for gender, or for even the smaller geographic units. This is possible for information where there's a lot of data in CHORDS. Race and ethnicity is still lacking a fair amount of information in CHORDS, as you'll see in a minute. So if you really wanted to weight by race and ethnicity, you would have to do more of an individualized query and do some kind of nearest neighbor or similar analysis, which has been done with CHORDS data by Kaiser researchers. When we look at something like diabetes, we can see that the weighting results aren't, you wonder if they're worth the effort. So the absolute difference for diabetes prevalence in adults was only showed less than a 1% difference, percentage point difference, adjusted versus crude. We see similar rates for gender, and in the very small age groups, those weighting factors end up being very small. So you may have to ask the question, do I need to do weighting? And there are experienced users who could probably help give you better advice on that than me. And then record linkage. Now, record linkage is going to have a big effect on things like race and ethnicity information, because an organization like Denver Health, which asks these questions fairly aggressively and consistently, that data will soon be able to carry over to data to other institutions who are also seen at Denver Health. So we anticipate a lessening of the no data, null sets in our record sets. Also, we anticipate that recent federal rules requiring EHRs to collect the information more appropriately and more regularly, and some other factors to improve that issue as well. Record linkage. So if you have a record at Kaiser, you have a record at Denver Health, and you end up being counted as 2 people, that's a problem. Can we link them? There are two approaches. The good news is I'm not going to go into the dirty details. But one approach is each institution sends a lot of personal health information, Social Security number, phone number, mother's maiden name, all that stuff, to COREO, which is used to dealing with confidential health information. And they match everybody using a probabilistic algorithm and assign a user ID to each case that can then be linked every time we make a query. So you'll know that John Doe at Kaiser and John Doe at Denver Health are the same. And this has been tested. It's now in quality assurance. And the various institutions are now in the process of doing this very ticklish job of getting huge amount of personal health information over to COREO so it can get crunched without it's being stolen or lost. We anticipate this to be available now at the end of 2019. As you can imagine, moving all that PHI around makes people nervous. So we are looking at a second model as well, letting each CHORDS data provider hash, that is to say, so deeply obscure that you cannot actually tell the difference, tell who somebody is, based on a patient's individual demographic information, but letting other providers do the same hashing in the same way with their demographic information and see if there are matches that way. That way you don't have lots of personal sensitive information traveling from one office to another. And that, we believe, we can start doing in 2020. We have a project from CDC that is asking us to look at obesity treatment outcomes across the city, and they have asked us to develop this methodology for that. When you try and remember what the hell did Dr. Foldy tell us, if you go to this website, you can get a variety of information sheets about CHORDS. And within the week, but unfortunately not today, the URL will be available, and I will try and distribute it to you through your faculty, that allows you to take some of those, prearranged queries and dredge them up either as PDFs or as dynamic map output. These are your two project managers. Rachel's in the room, I'm pretty sure. Yeah, there's Rachel, is in the room. And she more or less handles the research side of the equation, whereas Greg Budney in my office works very much with people who are seeking public health projects. And this is just a list of people who helped me with the slides. The list of people who helped build CHORDS would go on for slide after slide after slide. So at this point, I'm going to turn it over to Tessa, who is one of the architects of CHORDS, but had to do some significant statewide surveillance using electronic health record information before CHORDS is ready for her. And today, CHORDS is almost ready to do the kind of work she wants to do, except we're not statewide yet. But she can tell you more about the details. Are you going to be able to see where your slide? Yes. I think you're here.
Yeah.
All right. So Tessa Crume, who is one of your professors, happy to turn it over to her. And we'll answer questions after.
Well, thank you so much. For giving me enough time to talk about my work.
I try.
I really appreciate that. So I'm Tessa Crume. I'm an associate professor in the epidemiology department, and I wrote a grant in 2011 to develop a statewide surveillance system of congenital heart defects in adolescents and adults, and I wrote the grant with CHORDS, proposing to use CHORDS data. And then I was awarded the grant, and so we weren't quite ready to go live with what I had proposed in the grant, so I'm going to show you our workaround, which I will be very excited to use CHORDS in the future. So we constructed a surveillance system of congenital heart defects, and this is important because CHDs are the most common types of birth defects, estimated to affect nearly 1% of all births in the U.S., or 40,000 live births annually. The ability to perform open heart surgery with the introduction of the infant cardiopulmonary bypass in the late 1950s transformed many of these previously fatal defects into a lifelong chronic disease. However, the prevalence of congenital heart defects beyond infancy in the U.S. is unknown. Difficulties imparted by our disjointed healthcare system make understanding the adolescent and adult CHD population extremely difficult. So much of the research about CHD is done in European countries or in Canada where they have single-payer systems. So based on Canadian research extrapolated to the 2010 US Census, we estimate that there are 2.4 million people living with congenital heart defects in the US. However, research on the adolescent and adult population in the US is scarce. State-based birth defects registries ascertain incidence at birth. However, they utilize different methodologies, so collapsing across states to produce national incidence estimates are problematic, and extrapolating incidence at birth beyond infancy is inaccurate because about 40% of individuals are not diagnosed with a congenital heart defect until after 3 years of age. So survival with individuals of congenital heart defects has changed dramatically over the past few decades. On the left, it shows the survival pyramid for in 1987 through 88. And you can see that about only 25% of individuals born with a CHD survived beyond the first year of life. Contrasting that to 2004-2005, almost 85% of individuals survive the first year of life, and their population pyramid really resembles that of an individual without congenital heart defects. So this is amazing news, one of the biggest medical breakthroughs. But individuals with congenital heart defects have a challenging path, and they have much higher healthcare utilization and risk of adverse outcomes. So we developed the Colorado Congenital Heart Defects Surveillance System based on receiving that Centers for Disease Control grant. We are one of 5 states funded. And our goal was to develop a population cohort of adolescents and adults aged 11 to 64 years of age who were in active clinical care between 2011 and 2013. And we ascertained cases from a diverse network of healthcare systems, administrative databases, including the Colorado All Payers Claims Database, and public health data sets. Our goal was to describe the epidemiology and prevalence of congenital heart defects, to understand healthcare utilization and health outcomes, and importantly, to evaluate the strengths and weaknesses of this integrated surveillance effort for a rare chronic disease. So the steps that we have implemented over the past 4 years, and we're very proud of ourselves that we've achieved this in 4 years, are to engage healthcare organizations and public health agencies across Colorado as partners in surveillance. And CHORDS was, of course, one of the key members of our advisory group. And I'll talk to you about who our other data sources were on the next slide. We identified our cohort of CHD cases across all of the data sets. We performed a record linkage and deduplication algorithm to deduplicate within and across data sets. And we also evaluated the performance of our algorithm against that of Correo's algorithm. We performed case validation on a subset of our cases to determine how well our ICD-9, or our diagnostic code-based algorithm to capture CHD cases, performed against medical record review. And then we implemented a variety of analyses to determine the extent to which bias was introduced by incomplete case ascertainment. We engaged a patient advisory group of CHD patients and their family members that has met quarterly to help us evaluate our research approach and identify priority topics. And now we are disseminating findings. So our primary case finding data sources included Denver Health, Kaiser Permanente of Colorado, Centura Health, the Compass data warehouse that contains all care at Children's Hospital of Colorado, and the UCH Health System, and then the Colorado All Payers Claims data set out of the Civic organization. So across these data sources, we identified over 25,000 cases. We then performed We then applied our exclusion criteria, which was that they needed to be in active clinical care and have had an ICD-9 diagnostic code during our surveillance period consistent with a congenital heart defect. So they couldn't just have a history of CHD, they had to have that diagnostic code during our 3-year surveillance window. We excluded cases that were not residents of Colorado. So that left us with 16,480 cases. And then we performed our record linkage, and that brought down our final case finding data set to 12,293 unique cases. We then matched our unique cases from primary case finding with our secondary public health data sets. So we linked to birth certificates, not just for the index case, but also for live births occurring to women with CHD. So birth certificates were available for query on individuals born after 1975. We linked to 3,047 birth certificates for index cases and 1,031 live births that occurred to women in our data set. We also linked to the Birth Defects Registry at CDPHE, which captured critical congenital heart defects as a reportable condition after 1996. So this is the CRCSN Birth Defects Registry, and we only identified 162 cases. But remember, our case cohort was 11 to 64, so we didn't expect to identify that many matches. And then we linked to death certificates occurring between 2011 and 2017, and we identified 293 deaths. Our record linkage and deduplication algorithm was developed by Tone Ong, who is a specialist in the School of Medicine, Department of Pediatrics, and implemented by Lindsay Duca, my brilliant database manager over this project period. It was a probabilistic record linkage algorithm that was developed to compare available personal health identifiers on each individual and determine the likelihood that 2 or more records matched both within and across data sources. Our linkage variables included first name, last name, date of birth, the last 4 digits of the Social Security number, and street number. We divided our cases into 3 blocking schemes and then quantified a match score between 100 and 0. Perfect matches, of course, had a 100. Potential matches were between 99 and 75, and we manually adjudicated all of the potential matches with 3 reviewers, and then non-matches had a match score less than 75. We performed a variety of analyses to understand the implications of our record linkage. We determined that duplicate cases across healthcare systems and the All Payers Claims database significantly influenced our total case finding, accounting for greater than 25% of our total cohort. We found that our duplicate cases were more likely to be less than 18 years of age, have a severe primary CHD defect, have changed health insurance status during our 3-year surveillance period, have a higher level of all of the major CHD comorbidities, and have higher healthcare utilization. We concluded that the All Payers Claims database was a valuable case-finding data source as it contributed the highest number of unique cases during our surveillance period. It should be noted that All Payers Claims during our surveillance period captured 100% of Medicaid claims and 8 commercial health plans. It has changed significantly since then and now includes 30 commercial health plans. However, it captured fewer than 50% of the cases that it should have from the original case-finding data sources. Therefore, we've concluded that the All Payers Claims database was necessary but not sufficient for our surveillance needs. The brilliant Lindsay Duca completed an evaluated incomplete case ascertainment and how this affected our surveillance findings by implementing a capture-recapture analysis utilizing a Poisson log linear model. She considered potential sources of heterogeneous capture probability or demographic characteristics that were associated with the probability of being ascertained by our surveillance system and evaluated if dependency existed between data sources. She implemented 5 gazillion models and selected the model with the best fit that included interaction terms between these two factors and interactions between those two factors, and calculated capture-recapture adjusted prevalence estimates by dividing the number of true cases estimated by our methodology by the number of individuals in the source population, so individuals aged 11 to 64 residing in Colorado during our surveillance period. These are period prevalence estimates. So our crude estimate was 3.25 per 1,000 individuals. Our capture-recapture adjusted estimate was 5.85 per 1,000 individuals. And contrasting this to what would have been estimated based on the Canadian studies. So for the Colorado population, based on Canadian prevalence, we estimated our prevalence would be 4.09. So we were reassured that our crude and our capture-recapture adjusted estimate shouldered this estimate. The reason why our capture-recapture adjusted estimates were higher than our crude are due to a variety of factors not comprehensively summarized here, but those factors could be cases who did not access care within our surveillance window, CHD cases that access care but did not receive a diagnostic code for their CHD. So you go to the doctor, your primary care doctor, you have a CHD, they don't note that. Or cases that access care outside of our case-finding data sources. So we have so many findings, I can't possibly get through them in the next 3 minutes, so I would just say that we have assessed all of these factors, the variation in prevalence estimates by age, the healthcare utilization factors by a variety of important factors for CHD cases and comorbidities. But I'd like to touch on the public health implications of this work. Even after successful reparative surgery, individuals with CHD are not repaired. Most individuals have to have potentially several surgeries over their lifetime to correct the original correction. And they have a variety of health factors that are because of the initial surgery. So these individuals have complex life courses and require lifelong disease management. And as you would imagine, aging of this population brings unique challenges for lifelong cardiac care. One challenge being the transition from pediatric care to adult-centered care, which Lindsay also investigated in her dissertation. And this research helps us to realize that there are more individuals living with CHD than previously estimated. Certainly, if we based our estimates just on those ascertained by birth defects estimates, we would just see the tip of the iceberg. Critical CHDs is just the tip of the iceberg of congenital heart defects. And this has important implications for resource allocation to meet their complex lifelong healthcare needs. We hope that our project has helped to illuminate some of the strengths and limitations of this method of surveillance that is based off of the electronic medical record, insurance claims, and public health data sets, and can help to inform future researchers that want to look at other conditions or other rare chronic conditions, which the medical record is a very tempting data source for that goal. And we've shown that stakeholders across Colorado can come together to conduct surveillance. The Colorado School of Public Health, Kaiser Permanente, the CHORDS network, the state health department came together to share data to allow us to meet this goal. And we feel this was really unprecedented, and we are so grateful. And then finally, most importantly, we want to increase the awareness of congenital heart defects and advocate for the needs of these patients. So thank you so much. Any questions?
I did want to make one observation. So when I saw that 25% duplication in their work, I was surprised because much of the work we've done shows more like 8% in the general CHORDS area. that she was able to mention things like, well, you know, almost anybody with a congenital heart disease in Colorado ends up going to Children's at some point. That's certainly not true for every person with diabetes or other run-of-the-mill disorders. So that was something I learned from the presentation. It will vary greatly with the problem you are studying. Did we see a hand? Yeah.
Yeah. So this is a question for you, Dr. Foldy. How good is CHORDS at differentiating between a current diagnosis of X and a history of X?
I don't know. This is one of those questions I would call the project manager for. And I know there are going to be at least two different sets of variables there. You know, how clear doctors are in writing their text and how it's coded by coders. So it would not surprise me if there was some issue there, but I don't know the answer as to how it's being managed. Does anyone else?
So we are just starting to look into differentiating between diagnosis from the problem list and diagnoses that are associated with the encounter. So we do want to look at where a diagnosis is coming from and then the issues that Dr. Foldy talks.
Should we expect that our radio listeners are hearing questions or probably not? Okay, so the question was, how well can CHORDS differentiate history of a problem from current problem? And we had a second answer in the audience that said CHORDS is starting to look at the EHR problem list and the EHR diagnosis list to help triangulate that to some extent. But it's early work.
Yeah, we just added it this year. So I'm curious, Tessa or Dr. Foldy, so you were intending to use CHORDS but didn't. Do you think that the prevalence using CHORDS would have been similar? Because you basically had to do your own. So I guess underlying that question would be, how does what you put together differ from what you might have found in CHORDS?
So we could certainly assess that by looking at the case-finding data sources that we used relative to those we know are in CHORDS, or we could submit a data query and figure out what it is in CHORDS. Yeah. We have been in that process of trying to answer the question, what if you didn't have, we basically had 2 years of funding to support building partnerships, writing data use agreements, and we had the funding to pay for the data transfer. Most researchers, most projects are not going to have those resources. So we've been asking, what would happen if you just use all payers claims? And I'd say we're in the early stages of answering those, but we feel good about our coverage. It's not comprehensive, but it includes the major facility that conducts these initial surgeries, so the major pediatric provider, Children's Hospital. UC Health has the sole certified adult congenital heart disease clinic. And we feel good about our coverage of low-income individuals because between Denver Health and all payers claims, which includes 100% of Medicaid, we would like to think that our external validity is relatively good. But, you know, we finalized our cases a couple months ago, and we're like cranking out our findings really quick. So I don't say that I could answer that with complete confidence.
The point that I would make is that project used the virtual data warehouse of Kaiser and Denver Health, which was available to them at that time. Obviously, there are many more institutions since then, but they had to look well beyond those two systems for their case ascertainment statewide.
Yeah, so this is for you, Dr. Crume. In looking at diseases like congenital heart disease, where it would be really useful to also have data about the pregnancy and kind of data from mom and, you know, diagnosis, and because that certainly is, you know, evolving pretty rapidly as well, sort of how we diagnose and kind of what choices people make in their pregnancy. Are you able to, or do you think CHORDS will sort of help you link kind of mom and baby's records and sort of gain access to that piece of the information as well?
So the question was, would utilizing CHORDS allow us to better look at the complex nature of this disease that involves pregnancy? So the linkage of mom and baby's medical record, which is historically extremely difficult. And I know I approached CHORDS a couple months ago, and they were still challenged by that. I know most systems are challenged by that. We have tried to do it a backdoor way in our system by linking to birth certificates. So those would only be the live births of mothers with a CHD. We can't go in and just get the birth certificate data. We can only query it for cases we've identified in primary case finding. But we found that there are a lot of issues with trying to look at pregnancy. We have applied for a renewal grant, which in the renewal grant we've proposed to do surveillance across the lifespan. So we hope that that will allow us to better assess it. And we're also hoping to link to fetal death certificates in this next round. Another issue we've found is that often when the baby has a CHD, they've done fetal echo and they've detected the potential in the baby. There's not a baby medical record yet. The baby hasn't born yet. So that goes in the mom's record. And so we've had to try to disentangle how many of our cases was really a mom, an unaffected mom, with that code that went into the mom's medical record. And so we've had to do a specific chart review to disentangle that.
I thought I would say a few words about how people get bright new ideas into CHORDS data model. I mean, this would be a data model problem. How can the data model be developed in such a way that we start to capture mother-child linkage, for example? And that's done on an annual cycle because the healthcare providers really can only update their VDW once a year. So it could be brought to the CHORDS governance as an item, sorted out amongst the competing ideas in terms of practicality and cost and capability, and then hopefully rolled into a future year data model. Did you have your hand up?
Yeah, question for Tessa. Tessa, you mentioned that I believe there are 4 other groups that were funded on this project, similar to your project. Several questions about that, I guess. Do you have an opportunity to interact with those other groups? Do you have an opportunity to apply the methodologies on capture recapture that Lindsay has done here to those other states? Does this lead to a possibility of actually national prevalence for congenital CHD, thinking beyond the state and reaching out?
Yeah, so we worked as a collaborative between the 5 funded sites, and we implemented the same protocols for ascertaining cases with the goal of coming up with group estimates. We don't know yet if we're comfortable saying those are national estimates, but we got our capture recapture technique. We adapted it from a technique that was used at one of the other sites. And so I'd say 3 of the 5 sites have implemented a similar technique with a few tweaks. But at the national level, they aren't comfortable using that methodology to adjust our estimates for national estimates. We have just combined our data, our group data, and we're in the process as a group of trying to understand how far can we go in drawing conclusions at a national level.
Given you have an entree into the CDC chronic disease branch now, does that lead to an opportunity for national prevalence here?
Of congenital heart defects?
Well, this is definitely...
So Lindsay is doing EIS at the CDC in the chronic disease branch. I'll let her answer that.
Yeah. So we are tied closely to the birth defects branch, so I think they would definitely be interested in that. But yeah, we'll have to see all that before. Continue to, yeah. Exactly.
Yeah, they asked me when I was at CDC to talk about electronic health record information. Definitely, birth defects branch views this as a real opportunity going forward.
Okay.
Yes. Thank you, everybody, and to our radio audience.